Again, good afternoon, everyone, and welcome to today's Pediatric Readiness Recognition Programs Collaborative Session. Today will be our 14th session, and on behalf of the PRRPC team, we would like to thank you all for your time and dedication to the Pediatric Readiness Recognition Programs Collaborative over the last 16 months. And before we get started with today's session, we would like to acknowledge that the Pediatric Pandemic Network and the EMS for Children Innovation Improvement Center are supported by the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. As a reminder, today's session is being recorded and will be posted to the EIC website along with today's presentation. And as always, we look forward to having an interactive session with you all, so please feel free to raise your hand or come off mute throughout today's presentation. And we do look forward to hearing from more of our participating states and territories during today's session. So we have a packed agenda. So we're going to go ahead and get started with those state updates. And first, we will be hearing from the state of California. I can share the slides for you, or if you would prefer, I can hand over control to you.
You can share it. That's fine.
Okay. All right. Well, the floor is yours.
I don't see your screen. Just a second. Are you sharing the screen, the presentation?
Can I have someone else? I believe I am.
I can see it.
Someone else can see it? Okay.
I can see it.
Oh, okay. I don't see it on my screen. That's
Are you just seeing our screen with all the pictures of the?
yeah.
Zoom has changed its platform, so at the top it says meeting, and then it also says Casey's screen. So you might just need to click on that, and it'll sometimes shift.
Okay, perfect. There you go. It has changed. Okay. Hello, everyone. First, I want to give a little background on our two-tier. Can we go next slide? On our two-tier system. So the California Emergency Medical Services Authority, EMSA, we serve as a statewide oversight that's responsible for coordinating, leading, and planning and the development of the EMS system across the state. And we work with our local emergency medical services agency, which we refer to them as LEMSAs, who provides oversight at the local level by implementing state standards and providing coordinated system of emergency medical care. So today, there are 34 LEMSAs in California, and most of these LEMSAs serve a single county, but we also have LEMSAs that serve multiple counties. Next slide. So we implemented our EMSC regulations in 2019. Our regulations are in alignment with like the HRSA deliverables while addressing the unique pediatric care in the California EMS system. So earlier this year, we revised our EMSC regulations, and our regulations is not final yet, but we worked with our stakeholders and the LEMSAs to add proposed language to include language for pediatric readiness and the pediatric recognition program in our revised regulation. So for your reference, I've included like the draft language on the PowerPoint slide here. So we have a proposed draft language for pediatric readiness adding into our regulation, and we also have for the pediatric recognition program. Next slide. So here's a rough timeline of how we will be implementing our pediatric recognition program. So our draft regulation is anticipated to go out for public comment in 2025. So depending on the public comment period, we anticipate the revised regulation will be approved and implemented, hopefully no later than 2027. So what does this mean? So based on our EMSC regulations, the LEMSAs will implement their own pediatric recognition program, and the LEMSAs will be implementing when they implement the recognition program, they do submit an approved EMSC plan for review annually, and that happens with the state reviews and approves their EMSC plans annually. Next slide. So for the next step in our January quarterly meeting, our EMS Technical Advisory Committee will be reviewing like other state recognition programs to gather ideas, and we will be developing like specific criterias, benchmark, and toolkits for the LEMSAs to adopt and implement. And so what that means is, as I mentioned with our two-tier system, we will have each LEMSAs will be operating their own recognition programs. So that does mean that we will be having approximately, if we have all the LEMSAs submit an approved EMSC plan, we will have approximately 34 variations of recognition program in California. And that concludes what we have going on in California. Is there any questions? Don't see any questions in the chat. Well, thank you, everyone.
Thank you so much for sharing. If anyone does have any questions, you can feel free to message in the chat feature as well. All right. Well, I appreciate you sharing today.
No problem. Thank you.
All right. So next up, we have Montana. Again, if you would like, you can share your screen or I can share for you.
Why don't you go ahead and share for me?
Take it away.
Okay. Can you hear me okay?
Yes.
So thank you. I guess Montana got bumped up in the order. I was thinking I was going last, but no worries. So Montana has had an established program since 2017. We have a 2-level recognition program, which is prepared and capable. Prepared mainly consists of our trauma levels 1, 2, and 3, and pediatric capable is our critical access hospitals. Montana actually has emergency departments that go down to level 4 of trauma. So we have, level 5. So we have 4 and 5 at that level. Since 2018, we've recognized a total of 18 emergency departments, 7 of those being capable, 11 of those being prepared. The total listing of those hospitals is on our program website. Next slide. So our advisory board mission statement, I posted there. I won't read it to you guys, but the link to the actual members is right there. That's on our webpage. I would say this has been a barrier overall because our committee is non-statutory. So basically anyone who has an interest in children's health can join. The challenge has been getting providers engaged. So while there's providers that sit on the committee, they rarely attend. And that is a barrier when you have this robust of a hospital recognition program. So since I've been in the program since 2023, I think we're making progress that way. And I've recruited a few peds nurses, a few pediatric hospitalists. So I hope that I'll get more engagement on the actual recognition program through that. Next slide. Okay, so our application process can be summarized at the link at the top, which is our application packet. Our documents are all submitted through a secure file transfer, which the sender essentially just has to create an email account, and that medium is PII. PII can be sent through it, and also very large files can be submitted through it. So that works well for us, at least in Montana. The main requirements of the application is the successful completion of our recognition criteria checklist. That is actually not posted on our application packet simply because of ADA accessibility compliance regulations. So that's available upon request. So if the agency is interested in applying, they just reach out to me and I email that to them. But all of our other documentation is listed there, including our disaster preparedness checklist, our application process, and supporting materials for that. We widely disseminate and share both our pre-hospital and hospital recognition programs through various media. I put out a monthly EMSC newsletter. I participate in multiple committees because I'm in the Office of EMS. So I'm on our MSAC, our EMS Advisory Council. I'm on our Trauma Advisory Council. I attend, when I can, our regional trauma meetings and then our annual advisory meeting. And we promote and disseminate information on the recognition programs through those mediums. And then finally, we do maintain a social media presence, a smaller one via a Facebook PEC page. As I mentioned, I know some states have had issues with how to send and receive files. We have a state file transfer service that we use for that. And then, of course, I digitally save documents in our share drive. And then, as I said, hospitals that are recognized successfully are posted onto our state website. Next slide. So the verification process consists of a very small team of myself and a contracted pediatric liaison. And that is the process basically is that we request the recognition checklist and the disaster preparedness checklist at least 2 weeks before any scheduled site visit. And we evaluate both checklists internally, which includes submitting policies and procedures, and then also leading up to a site visit. If I might schedule a Zoom meeting, something like that, to talk with staff if they have particular questions. And basically how that works is if there's gaps in either of those checklists, if it's determined how we have the checklist weighted, that essentially the facility isn't ready to go ahead with having the site visit, we may return those checklists and say we still have these areas that you need to complete, and that we always promote readiness on a continuum. It's not that you're not ready, you just have to do X, Y, and Z to be ready. Or we may review both of those checklists and all of the questions are satisfactorily answered with supporting documentation. And at that point, I will schedule a site visit I have a demographic information form I send them. We strongly encourage that the C-suite is available. Understood in a hospital setting, that isn't always the case. But of course, the PEC and the ED staff, we coordinate a time to be on site. But the bulk of the pediatric readiness assessment is done before we do the site visit. And the anticipation is that they are going to be pediatric ready, save for the site visit if we were to find issues with a walkthrough in the ED, like not having a crash cart, not weighing in kilograms, which that almost never happens. And we limit that visit, we give them an estimated time of about 2 hours. Next slide. So sites are recognized as pediatric ready through the process I just explained. They successfully complete their checklists. We do a site visit. The site visit, in addition to our ED walkthrough, does include the facility presenting on their hospital pediatric data. So they do that short presentation. It's also a networking opportunity, try to recruit people to my advisory council, etc. So after that happens, we give an estimation of 30 days. It's usually done well before that. We put out an ED review report, and that report details the criteria met and identify strengths and opportunity for improvement. And then we also, I will snail mail a recognition certificate, and then this goes into an email to the PEC, a memo, and then a press release that we encourage the facility to share with our local media. They don't have to. And then that recognition is valid for 3 years. Next slide. This is kind of repetitive because I mentioned it before, but we do a lot of engagement here through our bi-monthly trauma designation meetings, newsletters. We put out a not only EMSC newsletter, but an EMS. We have all of the licensed EMRs in the state. It's like over 7,000 people. They receive information in a quarterly newsletter. I'm very involved in our annual trauma symposium. I always bring in pediatric speakers, so I attend that, and the advisory council, of course, and then our Facebook group. Next slide. So for future development, we've already addressed this, but we're continuing to explore our ACS verified facilities, how that can partner with trauma designation. All of our ACS verified facilities in Montana, which includes 2 trauma level 1 facilities, are pediatric recognized. And in fact, they're going on their 3rd renewal cycle of being pediatric recognized. So there's redundancy, and also it's a new criteria through ACS to be pediatric recognized. So we're in the process of just trying to streamline that and not duplicate efforts, but also learn more, because on our end, we're not exactly sure what ACS is asking for too. But potentially that would, we would partner with our EMSC review with our trauma designation review. A huge barrier in Montana is the vastness of our state. There's over 700 miles, and I feel kind of like a broken record when I say that, but when you're adding in our very limited budget to doing a site visit like that, it's, as I put at the bottom, when you add travel, per diem, staff's time away from their administrative work, that adds up. And we average, based on that 18, we have 65 emergency departments, 18 are currently recognized. We average about 6 renewal visits annually. However, since I've been new at the position, we kind of limited it in the previous year. So we only did about 3 last year, but realistically it would come to about 6, potentially even more annually, which again is a very significant challenge with our budget. Next slide. Next steps, as I mentioned, is getting provider engagement on the advisory council and helping incorporate the feedback from our provider networks into our review process. Currently, I don't bring up, because of the fact that I have such limited, honestly, feedback on my advisory council, but I don't have any like hospital staff really participating in it. I don't engage them with our hospital site visits, because again, a lot of those folks are outside of a clinical aspect. Potentially for our renewal sites, conducting virtual visits instead of in person is very possible. And then, as I mentioned, strategizing with our trauma designation team for our ACS verified facilities. Finally, with the volume of policies and procedures I receive, something I'd like to do is have a statewide document repository where I could share that information with other states interested in getting pediatric ready, because that's probably the most frequently asked question I get, is if they can have examples. The EIC is great, and I refer them to the toolkit. However, those aren't, just a specific policy that is used within the state, and also a hospital's cohort, because if they're a critical access hospital, they probably want to be able to know what a critical access hospital is using. So I don't know what that looks like. I just kind of do that ad hoc. And then also there's some privacy issues too. I don't just share a hospital's policy without their permission. Next slide. That was it for me, and I don't see any question. There was one question in the chat.
Like Pat has her hand raised.
Hey, Kelly,
Yeah.
you have a children's hospital in Montana now, right? In Kalispell, right?
Pat, that is an excellent question, and it's not a yes, no answer. We have a hospital that has children's specialty,
Mhm.
but they're not a trauma 2 level facility. So it has very there's, this is going into a different conversation.
But it's better than none.
It's better than none. Exactly.
It's definitely better than none, because I've talked to people up there. So there's always an opportunity if hospitals are in a particular catchment area for a children's hospital. It's a real win-win if the referring hospital, if the hospital that's being referred to can just share their policy, that where there's gaps. The other advantage of that is that it begins to set kind of a uniforms or some standard work in, regarding the care of children, or, a dialogue about that type of thing. So, I'd encourage you to look at that, and, even though, a hospital isn't, a level 2, or, as far as that's concerned, I think, in a situation like you are, where, there was no children's hospital, it really is it really helps, I think, bolster the engagement when you're giving recognition and facilitating that interaction between the new facility and the referring facilities.
I think that's great advice. And we are looking at, I'm actually going up there this summer to both of our hospitals in that region. So I'm surprised that you knew that, but look at that.
Well, thank you.
I apologize for my voice being harsh. I'm just getting over a cold.
Yeah, so am I. So yeah, I know that region very well, actually.
Thank you so much, Kelly.
Thank you.
If there are any other questions, feel free to message in the chat feature. Next up, we're going to be hearing from Pennsylvania. And Dwayne, same goes
I'll
for
have
you.
you advance slides for me, please.
Would you like me to? All right.
The next slide. So good morning, good afternoon. I should say thank you for allowing me to present our programs. Our Prepared for Pediatrics program includes both ED and emergency medical services components. And I'll apologize up front because I am not 100% either. So our ED program development began in 2023, back in June, by establishing a statewide steering committee. And that committee spent the next 9 months creating a program outline and basic requirements. In January of this year, we began to recruit interested facilities to participate in a pilot development phase of the program, where pilot facilities and the steering committee work collaboratively to assess requirements, determine effectiveness and applicability across one of 3 levels of recognition, and to ensure the program can be implemented at all levels of emergency department capacity. We presently don't have an ED recognition program, so we're starting from ground zero. This phase is continuing at the present time. Our EMS program has been active since late 2013 and presently has 263 agencies recognized across 5 cascading levels of requirements. So if you're a basic level, you only required to have the additional pediatric equipment. At the intermediate level, you have to have the equipment and background checks, and the checklist there demonstrates that our PEC is only required at the current program at the master and expert level, and that was added back in 2019. Next slide, please. So our EMSC advisory committee is comprised of representatives from all 8 core roles and 4 additional representative roles as defined in the implementation manual. Due to our EMS system design, we also have included additional roles and representatives on the committee as we feel fit. The advisory committee is tasked with reviewing and approving projects being created by the EMSC program. And currently EMSC is housed within Pennsylvania Emergency Health Services Council, which is the statewide EMS advisory board established through statute. An established process requires committee level approval for any projects to then be presented to the PESH board for action as a VTR, a vote to recommend, which is then submitted to the Bureau of EMS for review and either approval or return with comments. The Prepare for Pediatrics program will have an online web form and available electronic fill-in forms for applications. And this is the new program that we're working on. I'll go into more detail. Currently, application is via documents that can be downloaded and submitted via fax or mail. Additionally, documentation will be electronic fill-in forms and submitted as attachments with the application, either through the web form or through an email attachment. All forms are going to be available via our newly revamped EMSC website, which is due to be live in the next couple of weeks. And that revamp was due to a lot with the change in our programs, the refocus on priorities, and just getting it up to a little bit more current technology, more mobile friendly, things like that. Application data is going to be stored in a dedicated database, which we're actually currently working on to develop. Right now, everything's on spreadsheets, and I say that in plural, and it's a little bit difficult to facilitate when you're working across more than one spreadsheet. It's also difficult to address that we have over 800 EMS agencies that provide 911 and 170 hospitals worth of information. So the goal is to kind of bring that together in a coordinated effort that we can manage better. Our verification process for the programs, it will include a review of all the submitted documents to the program manager and at least one other team member prior to any site visit. For new applications, we're going to be requiring in-person site visits, which will be scheduled to meet with key agency or facility personnel, as Kelly mentioned. Getting the C-suite engaged early and frequently, I think, is the big key for the success of an ED program. But similarly, getting EMS leadership engaged and on board helps maintain the process moving forward. Renewal and upgrade applications are going to be handled virtually, and that's simply because of the numbers. Travel, the number of applications, again, through budget and also personnel, we just don't have the bandwidth to do them in person. So for EMS recognition, we're also utilizing our regional EMS council for assistance with the supportive inspection of the additional equipment and supplies required of the program above that's already required through licensure. And that process is already well established for licensure, and there'll be a supplemental form that the inspector goes and has in place when an agency is recognized for pediatric readiness, that they just make sure that equipment is on each of the licensed units. Recognition is going to be facilitated at the completion of a site visit with certificates and media information, along with vehicle decals for EMS agency recognitions. We currently use decals. We're changing it a little bit, but so that people know it's the new program. But the decals are that public display as the ambulance is pulling up to the house or driving down the street of their ability to care for pediatric patients. Everything's going to be available at the end of a successful in-person site visit or by mail for virtual visits. And our recognition terms for both programs is going to be 3 years. Right now, there is no term on the EMS program, and that's one of the major feedbacks we received about is having it so that it's ongoingly maintained, that there's an accountability process with a term. Next slide, please. So our ED program development includes the steering committee outline and the pilot development phases, and it's going to allow those pilot facilities first opportunity to apply for recognition once the program is live. The pilot development phase is key to assuring our program meets standards and expectations while being implementable across all levels of emergency department capacity. Engagement of key PA industry affiliates will facilitate awareness of the program across leadership and clinical provider roles. That would include ENA, ACEP, our hospital and healthcare association, and the Pennsylvania American Academy of Pediatrics at a minimum. But we're still building that into our marketing plan. But I do note that early buy-in at any facility or agency and early involvement with the process will assist that acceptance of the effort to become pediatric ready. With industry, whether it be healthcare or pre-hospital, there's a lot of demands and stressors already. So adding one more to it has to come with some sort of benefit, and that'll be the sell to keep people engaged. Several barriers in the ED program thus far include a slower than expected pilot upstart. It took a little bit longer to get hospitals on board, and that is simply a factor of healthcare and where they are and the amount of time they have to dedicate it to something new. Also, a split in opinion over the need and level of physician competencies, and a slower than expected development of the national minimum standards that were planned to use as a basis for the initial level recognition. You know, we worked through that, and we're utilizing that information as a core to build from to work with those requirements and address any additional that our steering committee had felt was appropriate. Next slide, please. So at the core of our ED program are 7 focus areas with minimum requirements across each recognition level, either as a standard for all or an escalating level. So in one case, for example, the pediatric emergency care coordinator is a either or for the initial level, but required both at the upper level. Next slide. So moving on to our EMS program, we put together a team comprised of EMS stakeholders early in January of this year. It included PECs, educators, agency leaders, EMSC program leadership, and EMS providers. And their task was to review the current program and identify any need to revise it based on current industry expectations and standards. The team chose to reduce the program from 5 to 3 levels and consolidate what we're referring to as the legacy program requirements into the initial recognition level of the new program, adding components of the HRSA standards that are not addressed elsewhere in regulation or protocol throughout the program. So one of the standards, talked about safe transport. That's already in our protocols. It's been there for years. So we don't need to address that in a recognition program because it's part of agency licensure. The legacy program needed to be enhanced with better guidance, a better application access, and compliance accountability across the board. So those items were addressed and considered in developing the new program. The program needed to be implementable, not just words on a paper, and sustainable over time. Knowing our existing program is over 10 years old, it's been well worth the time put in developing, but it was time to see where it could be better, and certainly the industry standards and national guidelines out there help drive that. The team realized there would be costs associated with certain requirements. However, it could not address these costs specifically as they vary by EMS agency licensure level, current activities and preparedness, and size of the organization. But to apply for the program, there's no charge to EMS agencies. Next slide, please. Some of the barriers for the EMS program included a concern that with increased effort to meet the expanded requirements, it would be a reduction in program participation. And we felt that the importance of the additional requirements and the more in-depth pediatric readiness was worth that, and that if agencies really want to participate in the program, they would take the extra effort. Additionally, the ability to meet the disaster plan requirement in the implementation manual was an issue of discussion, where Pennsylvania EMS agencies typically work across local, regional, and statewide disaster responses, led to some adjustments in terminology. Lastly, was the ability to coordinate the program over the nearly 850 EMS agencies that are 911 responders. We actually have over 1,200 licensed agencies, but the remainder are non-911, either routine transports or specialty type of agencies that don't have a 911 component. The daunting requirement, as mentioned before, about maintaining a contact list and information regarding an agency is a huge task, and that is what drove the need to change and have a centralized database to be able to track EMS programs specifically because of numbers, but we're adding the hospitals in well just because it's an easy add. Next slide, please. So the result of our revision is a 3-tier program over 11 levels of requirements. Our PEC was expanded to be across all levels. We revised our additional equipment and supplies list based on national recommendations, and that is consistent at every level. Education was expanded to include language around skills and competencies, and does have a bit of a cascading level, but also addresses licensure level. So a QRS service doesn't have the same requirements as an ALS service. Next slide, please. Community outreach was in our existing program, but we expanded it to focus on prevention programs in place of general outreach. And the legacy level, expert level child passenger safety component remains a requirement at the upper tier, but is offered as an option to the lower tier. That's kind of outside of a lot of the requirements through HRSA, but we felt that program was very positive in our state, and we wanted to maintain it and offer it to any of the levels of recognition that we're applying. Next slide, please. Then lastly, the performance improvement, disaster readiness, and family-centered care components were added to the program, and our NEMSIS and survey participation requirements were clarified. One of the requirements of any recognized EMS agency is they participate in any EMSC survey. Next slide. So the EMS program process requires an application for all new, renew, and upgrade activities. And agency licensure status will be verified and documented through the Bureau of EMS. That verification is to make sure there's no actions against the agency that the recognition program needs to be aware of. Once all items are verified, a site visit will be scheduled in person for new, virtual for others. Site visits will be coordinated with the appropriate EMS regional council for their support. And as I said earlier, vehicle decals, recognition certificates, and media support information will be provided upon successful completion of the site visit. Next slide, please. Our next steps include continuation of the ED pilot development phase with an expected completion of June of next year, and a transition to program document development and engaging the Department of Health with a substantial product for the review and comment prior to finalizing the program. Once approved, the program will be heavily marketed across the state, across many different stakeholder levels of agency or participants. Our EMS program is in the final approval process presently as we continue to finalize support documents in coordination with the Bureau of EMS. That was submitted actually last week. It was finalized through our internal process, and the Bureau has it to review and provide us the feedback. With that approval, the program will also be marketed across the state in preparation for a projected April 1st, 2025 go live and application acceptance. The one thing I do want to add is with the 200 plus currently recognized agencies, it's not a requirement for them to transition to the new program right away. We're going to utilize the triannual licensure renewal date as a date for the program as well, so that we'll be able to spread out some of the transition of currently recognized programs to the new program, but also to make sure that we're not heavy one year and light on another as far as any renewals go. The only unknown is the number of EMS agencies that are part of the program that happen to be part of that renewal year. may be a little heavier, but that'll be by chance, and certainly we can't control that. And I believe that's it for me. Next slide. Any questions for me? Thank you.
Thank you, Dwayne. Great example of sort of transitioning an existing program and involving some new criteria. So thank you for that. Next up, we have Ohio. And if you'd like, I can hand over the screen to you, or I can share the slides.
I actually had to update one of my slides, so if I could share, that would be awesome.
All right.
Let's see here, bear with me. Maybe. Hold up here. Okay, is everybody seeing the presented slide?
No.
No.
No. Uh-oh. Are you seeing the?
Just the
what a-
pictures. Just the people.
Okay. Stand by here, sorry. Oh, I have to hit the other share button. My bad.
There you
How
go.
about
Jess.
now?
You're good.
Sorry. My name is Jess and I'm new to technology. I am the state program manager for Ohio, and I should be joined by my associate program director, Dr. Ann Runkle. Excuse me, and I'm going to be talking about our ED recognition program, which we've named the Ohio EMS for Children Pediatric Readiness Facility Recognition Program. And our development did start at the PRRPC launch at the El Grantee meeting in September of 23. Our program is voluntary and consists of 3 tiers: Pediatric Ready, Advanced, and Comprehensive. And just a real general overview of the difference between our tiers. We expect most of our EDs and freestanding EDs to apply for the Ready tier, which would entail an MPRP score of greater than or equal to 90, a physician or a PEC, or excuse me, a physician or nurse PEC, which can actually be shared amongst multiple departments if they work within those departments. There are pediatric inclusions in their disaster plans and drills, and their QI includes pediatric deaths and safety reports. They also have to have equal or greater than 90% of all the MPRP checklist items, excluding the high volume requirements. Our advanced tier is the above, with the difference that their doctor and nurse PECs have to be dedicated to that particular ED only. They also have to have pediatric inpatient capabilities, 24-hour emergency medicine board certified or eligible coverage, and their policies have to include the death of a child in the ED. They have some more disaster requirements, and their QR requirements include pediatric specific indicators. And for the comprehensive tier, we actually have 6 children's hospitals in Ohio. We're pretty lucky. We expect it's going to mostly be those. So it includes all the above requirements, plus their MPRP score has to be greater than or equal to 95. They have to be a level 1 or 2 trauma center with a PICU and a NICU, and 24 hours of emergency medicine or pediatric emergency medicine board certified or eligible coverage, with 24-hour nursing, pediatric nursing coverage. They have to also have a policy for bereavement counseling, and obviously some more disaster requirements. They also have to have demonstrated pediatric educational outreach to the general facility or general EDs within their catchment areas. And their MPRP checklist requirements do include the high volume ED requirements. We did open our application late October, early November of this year, and actually got our first applicant earlier this month. A lot of stakeholders on our advisory board, some of which are on this call I saw. A lot of them are also involved in the development of our program, but we have representation from trauma, disaster and the Centers of Excellence, which includes Region 5 for Kids in our area, the Pediatric Pandemic Network, obviously the EMSC program. We have representation with ENA, ACEP, American Academy of Pediatrics. The FAN that we had was involved in our development program, actually had to step down to do some personal obligations. So we're looking to fill that FAN seat on the advisory committee right now. We have rural representation, out of hospital representation, and representation from the regional healthcare coalitions. We originally had a seat dedicated for the Ohio Department of Health, but they actually just got licensure of hospitals added to their responsibilities. So they felt it would be a conflict of interest to be on this particular seat. So we partner with them and rely on them for the program because they hold the hospital preparedness program grant. So we work with them a lot on the RHC side of things, but they don't actually have a seat on the board. The stakeholders' roles include general oversight and guidance of the program, which includes program policies and procedures. And they'll be helping us select and train site visit facilitators, some of which will be advisory board members themselves. They'll also review application packages, which will include a summary of the entire application from me, plus any of the reports that come from the site visits. And then they'll vote for final approval or denial of recognition and review any appeals on an as needed basis. But most importantly, they're going to support pediatric readiness throughout Ohio overall. The initial application is more of an interest application. It's posted on our website and asks for demographic information, what tier they're seeking, and their personnel and PEC information. After they turn that in, I will return to their primary contact with what we're calling a pre-site visit questionnaire that asks the facility's definition of a pediatric patient, because Ohio code actually has multiple definitions. So maintain consistency, we decided just to use the hospital's definition for their application. We ask about pediatric admission capabilities, their processes to write and approve ED policies so we can assist them if we find any areas of improvement there. We ask about average pediatric volumes and the number of specific kinds of PEDS cases seen in the previous 12 months, such as pediatric intubations in the ED, any transfers, trauma activations, and so on. I'll also send them a checklist according to whichever tier they're applying for. That includes the procedures and policies that they need, any equipment according to that PRRP list and so on. And then I'll set up after they get all that information back to me, I'll set up a pre-site virtual meeting with their primary contact just to make sure that the package is complete, any clarifying questions are answered on either side, and to start kind of working on the pre-site visit. And the goal of that meeting is to make sure that we're fairly confident that that hospital is going to be able to be recognized before we actually go to the next step of a site visit. And that site visit is in person, and I'll cover that in just a second here. All of our data is online, electronic, and it's stored on protective drives within the hospital where our grant is housed. There we go. So our verification process. The site visits for initial application are going to be in person across the board. We're a brand new program, obviously, so we haven't had any renewals yet. We're going to be on a 3-year cycle. We're looking into the potential to have some virtual or hybrid verification site visits down the road. But at this point in time, we're expecting at least 2 to 3 site visit facilitators per meeting. And we encourage hospital personnel attendance and participation as well, to include administration from the C-suite, the ED nurse manager and directors, the physician medical director, obviously their PECs. We'd like to have at least 1 staff ED physician present, along with representation from trauma, quality, and emergency preparedness. You can see the draft agenda on the slide there. We give an opening statement for the hospital to be able to present what they're proud of and what they've accomplished in pediatric readiness that's not necessarily captured in the application, and just their moment to brag. And then we go into an NPRP review and discussion. This is going to be a bi-directional chat and just discuss the findings in there and what they've done to work towards the score that they've earned, and if applicable, how they can improve their scores some more. And then let me see here. Oh, we then go into a chart review. So we give a list of 10 categories that we want the facilities to pull charts from, and then each facilitator is going to review 3 to 4 of these charts with the assistance of someone from the hospital to help navigate those charts. At which point the facilitators will then go into a private meeting where they can kind of collect their thoughts, make sure they've gotten all the questions that they need answered, and to prepare for the exit meeting with the hospital. And we just really want to be transparent in the whole process and make sure it's an encouraging and non-punitive process. And after the fact, the facilitators will complete a site visit report that I can help them with, and that will become part of the application package. So the actual recognition process, our committee meets on a bi-monthly basis. So once the package is complete, the committee will review it. They're going to vote on the recognition or otherwise. And a final report with the strengths and opportunities for improvement for the facility will be sent to that facility along with recognition or the next steps on how we think they can improve and seek recognition. English is new to me today as well, sorry. So the program development, the key for us was actually the involvement with the Ohio Department of Health and the regional healthcare coalitions, which was actually also part of our barriers. It's pretty cool because, as I mentioned before, ODH holds the hospital preparedness program grant. So they created a deliverable for the RHCs to put out to their regions that includes, I think, 70 or 75% of the hospitals or the ASPR participating hospitals in the regions have to complete the NPRP within 3 years. So that's going to help us boost those numbers as well and just get pediatric readiness awareness out there. Then the RHC coordinators are going to meet with all the hospitals, kind of give a presentation overviewing the program, answering any questions, and have the hospitals or freestanding sign an attestation designating whether they intend to apply for pediatric readiness, if they have any questions or if they need any assistance, so on and so forth, just kind of giving us a litmus test and letting us know what to expect down the road. Oops, you know what? I skipped over. I'm sorry, the barrier part. Since it is an RHC deliverable and we are running on different grant cycles, we're a little bit limited in how much change and flexibility we have now that it is part of their deliverable. So we have to kind of time any modifications to jive with their deliverable so we don't make them deviate from what they had submitted. But our next steps are to start recognizing facilities, obviously. And then as new evidence and data emerges and new guidance from the PEDS Ready project come out, we're going to fine tune the program. And obviously, as we start doing some of these site visits and working our way through the processes, we're going to, I'm sure, find some hiccups that we need to work on. And then we need to adjust as the RHC deliverable evolves. So that was super quick, but I am able to answer any questions that you guys might have.
Yes, I have a quick question.
Yeah.
And this is not specifically to you, but it came up in your program and it's come up a conversation on our end. How important are the chart reviews, the clinical side of pediatric readiness to your program, and why included, or was it something under discussion? I'm just curious.
It's actually an excellent question. And the overarching idea behind it is that's how we're going to verify that they're actually doing what they say they're doing. It's how we know that they're following their policies and procedures, because anybody can write up a policy and throw it at us, and we don't know if the ink is still wet on it or not, or if they've actually implemented it. So that's kind of our way to help prove that they're following the processes and that they truly are pediatric ready. I don't know if you have anything to add to that, Dr. Runkle.
One second, let me unmute myself. I think it is, we don't know exactly how this is going to turn out. So when we were initially developing our program, we heavily modeled it off of Kentucky's program, which includes chart review as a key portion of their site visit verification process. And they found it had been a valuable part of their process. In discussing with other states, many states, and I don't have an exact number, do not include that as part of their process. But I think the hope is to have them see some good examples and some examples of their standard patient care and see if they are following policies and procedures that they say they are doing. I think we are going to see how this goes. And again, because we're on a different cycle than the ODH HPP program. If we're finding we're getting nothing additional from the chart reviews, or we're finding we get very conflicting information from the chart review versus the application packet, we're going to have to reevaluate it. But for now, this is what we're going to start with, and we're going to see if it is a valuable portion of the site visit.
I had a question for you, Jess and Dr. Runkle. I had the same thing with chart reviews, but then also, what are you paying if you are paying your site reviewers? Have you discussed that?
We have.
And what is the credential of someone who does the chart review? two questions, I guess.
To answer the first question first, I believe it is a $250 honorarium for the site visit, and then we would be reimbursing their mileage, and that's going to be supplemented by, we actually are charging an application fee for our program. Pediatric Ready, I want to say is $500, advanced is $1,000, and comprehensive is $1,500 to help cover those charges or those honoraria and expenses. And the vast majority of our committee are all clinical, and a good chunk of them are physicians. So, and we aim to have at least one physician and a nurse or medic on the team of site reviewers, and we will not have a non-clinical person doing chart reviews.
Thank you. Yeah, good to
Cool.
know.
Anything else? Awesome. Thank you very much, and feel free to reach out if you have any questions later.
Thank you very much, Jeff. All right, next up we have Texas.
Okay, thank you very much. I'm Sally Snow, and I'm going to be talking about our hospital recognition program. Our leadership includes Dr. Catherine Cathari, who is our program director. She is board certified PDS doc and a board certified EMS physician. Sam Vance is our program manager, has been our program manager more than once over the years, but has been back now for a little while. And I serve on the advisory committee and contract with the program as a voluntary pediatric recognition program coordinator. And I also am the lead facilitator for our site visits. Next slide. So the reason we consider developing a pediatric recognition program, we must be fading these in, Casey, is to increase the awareness of pediatric readiness in our emergency departments, to have some minimum standards for pediatric emergency care, to verify what pediatric resources we have using our virtual site assessment, to minimize our pediatric patient safety events and address gaps in access to emergency care. Next slide. Just some context for the size of the state of Texas. The top left picture is the state of Connecticut imposed over the metropolitan Houston area. The bottom, middle, and top right pictures are the state of Texas superimposed over different sections of the United States. And the bottom right is the state of Texas superimposed over Europe. We have, in the state of Texas, Interstate 10 runs 180 miles from east to west. By comparison, it's 841 miles from Dallas, Texas to Sioux Falls, South Dakota. And from north to south, it's 900 miles from the Oklahoma border to the in the Panhandle to Brownsville, Texas on the Mexican border. So a large area to cover. Next slide, please. In terms of acute care hospitals, we have in 2007, we had 530 acute care hospitals. In 2017, that went up by about 7% to 565. And is now in 2022, the last time I could find that data, is down that 7%. So our hospital numbers are very high but fluctuant. Next slide, please. Our designated trauma centers are designated, our level 1s and level 2s by the American College of Surgeons, level 3s and level 4s by our Texas EMS Trauma and Acute Care Foundation. All trauma centers then, those are verifications. All trauma centers are verified or designated, by the Department of State Health Services. We have 22 level 1 trauma centers. 3 of those are children's hospitals, 28 level 2s, 2 children's hospitals, 56 level 3s, 2 of those are children's hospitals, and 190 level 4 trauma centers. The number of trauma centers in the state of Texas is down from 302 in 2003 to 296 at this time. Next slide. Just briefly, a historical perspective. We started this process through the establishment of a statute that established the Pediatric EMS and Advisory Council in 1993. Yes, that's the 1900s, and it was 30 years ago. In 1997, we started our PEMSAC decided to develop criteria under the leadership of Dr. Joan Shook, We developed some facility criteria and decided to apply for an EMSC grant and do an 8-hospital pilot, which we did conduct. We demonstrated through that pilot that there was a big need for improving pediatric readiness in hospitals in Texas. We presented our data to the Governor's EMS Trauma Advisory Council and hit a huge roadblock when they said, oh, that's really good, but there's no money to fund it. So things kind of stalled there for a little while, and we had our pediatric emergency medical, our pediatric committee of the GTAC Council continued to support pediatric education requirements for EMS. We tried to get our medical directors in EMS to adopt a standard set of equipment. They resisted. They didn't want to be told what to do. We did a resolution to call for limiting ionizing radiation and the need for image gently protocols. That passed. We had a document created that was posted on the GTAC Pediatric Committee page that called for fewer CT scans to be done prior to transfer. The GTAC Peds Committee also developed and documented in 2006 a pediatric considerations for consultation and transfer document, which was approved by the GTAC Council, and that is currently under revision to update it. So we continued to work through what we thought wasn't important at the committee level, even after we were told we couldn't implement our program that we'd been working on for so long. In 2009, new life was breathed into our grant when it was moved from the Department of Health to the Baylor College of Medicine. And that's when we kind of really got serious about what we were doing. Next slide, please. So we had new life, but did we? So the first thing we did once we were at the Baylor College of Medicine in 2009 was establish a timeline for when we were going to move forward. The next best, or the best thing that ever happened to us was Dr. Kate Remick came home to Texas. With all her vast experience with the EDAP program in California, she helped us sustain the momentum that we had been working on for so long. We held several intensive stakeholder group meetings to identify barriers and keys to success. We had a lot of success getting our stakeholders to say what those barriers were, and they ranged from administrative resistance to we don't have the staff to we don't care about it, all over the map. We developed more criteria. We joined the EIIC Facility Recognition Collaborative. We took a plan for a voluntary recognition program to the Governor's EMS and Trauma Advisory Council, and Dr. Remick presented that proposal to 8 different GTAC committees who were identified that that was a good idea. We began to identify our pilot hospitals. And in 2017, we lost our state partnership manager and our state partnership director and yet again stalled. So in 2018, we had a new set of leaders for our state partnership. We had an application, a virtual assessment process, and training manual for facilities that was developed. Next slide. In 2020, we launched our program. We, of course, right at 2 months after COVID hit. So we quickly realized that there was no site visits happening. We trained 2 nurses and 2 physician facilitators. In 2021, Sam Vance came back to our program as a state partnership manager, which provided a great deal of stability, and Dr. Kathari became our program director. I then contracted with the program to be the VPRP, Voluntary Pediatric Recognition Program Coordinator. And we conducted our assessments using a hybrid model where most of us are virtual, but if there's someone in the regional, in the region with that hospital, then that person can be on site. It's mostly virtual. We've had very good success with that. Our assessment reports are presented to the EMSC at Texas Advisory Council for approval. And we have 3 Texas hospitals currently recognized, with another 20 plus in the pipeline that have expressed an interest. Next slide. So what we learned in building our recognition program is one of the barriers is size matters. In-person assessments was just not feasible for us. We have a huge, as you saw, number of hospitals. We had no legal mandate for this. We had no funding outside what we can muster up with the state partnership grant. And you guys know that every state gets the same amount of money. All of our staff that are employed have to be paid by the grant. We don't have any support from the Department of Health or the university other than office space. The lessons we learned were to build a strong stakeholder group and maintain historical perspective because we have a lot of history. Don't recreate the wheel, take advantage of the opportunities. We had to collaborate with people and take a leap of faith and just do it and see what happened. Next slide. Here are some of the voluntary pediatric recognition facility program partners. Early on, we had support from the Texas Pediatric Society, the Children's Hospital Association of Texas, and the one group that's always been steadfast in support of this program is the Texas Emergency Nurses Association. We get all our fan reps from the Texas Parent to Parent organization. We have 3 very active fan reps that move in and out that are all members of the Texas Parent to Parent organization. Texas ASAP helps, the Texas Hospital Association, the Texas EMS and Trauma and Acute Care Foundation is a big help to us. All of the regional advisory councils, all 22 of them in Texas, make up the TTAF. The Department of State Health Services, the Office of Rural Health, the Governor's EMS and Trauma Advisory Council, the Office of Trauma and EMS, and the Hospital Preparedness Program are all stakeholders in our group. And lastly, one of the things that happened to us recently was on August 1st, the Department of Health adopted brand new trauma rules, which is the first time our trauma rules have been revised in 20 years. Pediatric readiness is a mandate in the Texas Trauma Center EDs by rule. Implementation will take place 1 September 2025. The NPRP assessment has to be done annually. A quality improvement and disaster plan that includes pediatric patients is part of the package. Pediatric trauma simulation, including physician participation, is required every 6 months. Pediatric nursing education is required, and there are standards for assessment, vital signs, and imaging that's included. This was a major coup for pediatric readiness in this state. We feel like that the new trauma rules will increase the demand for pediatric facility recognition, and we anticipate that hospitals and the Department of Health may see pediatric recognition as a way to verify compliance with these new rules, because all the things that it takes to be pediatric ready in Texas are included outside of the simulation piece, and that's pretty easy to verify by looking at records of attendance to simulation. So we also have been very lucky to be participating in a Toyota grant project that has allowed us to take simulation to all of our racks. Every hospital in the racks have been contacted and offered an opportunity to have a regional pediatric emergency care coordinator come in and do simulation with their staff to meet that requirement of the new trauma rules. And it's been very successful. So we're looking forward to just keeping on doing what we're doing, even though it's taken us 30 years. We feel like we've made strides and success since, and this new trauma rule is going to really boost our participation, we think. And there are any questions? Thank you for your time.
Thank you, Sally. I see Mike has his hand raised.
Hi, Sally. Great presentation. I'm just curious, do the level 1 and 2 trauma centers also have to take the assessment annually since they're verified by ACS?
Yes, the trauma rules for the state of Texas supersede the ACS. So they all have to do all of these things that are required for all hospitals. And it's my understanding, and I don't know anything for a fact, but that the ACS is considering upping their game when it comes to pediatric readiness. So yeah, they all have to do it annually. Yeah, and anybody who wants to hear more about the trauma rules, I'm happy to share them with you. I'll put my email address in the chat, and I can send you the draft or the final approved rules, and you can start on your state.
Thank you so much, Sally.
Thank you.
All right. Next up, we'll be hearing from Chelsea.
Hey, can you see? Oh, there we go. Okay. Hey, everyone. My name is Chelsea Doobie. I am the EMS for Children Program Manager at the Vermont Department of Health. I'm going to be primarily talking about our pediatric, our pre-hospital pediatric recognition program, but at the end of the presentation, I'll touch upon some of the work that we're doing on the hospital side. I always include pics of my two little ones when I do presentations. They're my inspiration and why I do the work that I do. That's Michael at the bottom in the firefighter suit. He's about almost 6. And then Kennedy is my 8-month-old daughter. So next slide, please. So our EMS pediatric recognition program started back in 2020 around COVID by my predecessor. She called it Pediatric Safe. It has been recognized by HRSA. It was revised when I became the program manager. Not really like any huge revisions, mostly just trying to shorten the application packet was like 20 pages long and I condensed it down just to make it a little less intimidating for folks, things like that. It's going to be further revised next year in 2025 to incorporate more of the HRSA requirements around disaster preparedness requirements. And currently it's 1 tier. So you're either recognized or you're not recognized. We have 166 licensed EMS agencies in the state of Vermont. Currently 22 are recognized as being pediatric safe. That's about 14%. And I have about another 4 that have reached out expressing interest and will hopefully be completing the application process pretty soon. Next slide, please. So this is a snapshot of our scoring sheet. So what happens is interested agencies will reach out to myself or the EMS for Children program email address, which also goes to me. And then I send them information about the program and the application that's also available on our website. They can fill it out a couple different ways. Folks can either complete it by hand and email it in, or they can do it through like a fillable PDF. And then our EMS for Children Advisory Committee, they review the applications using the form snapshot that you see on the right. And if there's any questions or anything that we think are missing or need more information on, we'll reach back out to the agency and ask for clarification. And then we follow up and say a decision is made within 30 days, but we usually make a decision sooner than that. And so far we haven't rejected anyone. We've just asked people to provide clarification or additional information that we're looking for. We haven't flat out said no yet. Next slide, please. So currently there are 6 requirements, and this is what's going to be looked at and revised in 2025. But requirement 1 is that they have to have a pediatric emergency care coordinator. They have to have the required pediatric equipment that is listed on our health department EMS website based on their level of service. They have to be submitting electronic EPCRs to our state's NEMSIS compliant system, which everyone's doing now because that was made as a rule. So that's like mandated now that people have to do that. So it's not super applicable now. Folks have to commit to participating in any EMS or children related surveys. They have to send in an outline of their planned community outreach events that have pediatric focus for the following, at least for the following year. And then they also have to send a plan for the pediatric education and training skills that they are doing at their agency. And then I track everything in an Excel spreadsheet. Next slide, please. So promotion of the program, we have approximately 3,500 EMS providers in the state, and we send out a weekly EMS newsletter. I'll try to put it in there, just promotion of the program. We also do regional EMS meetings where our office will travel around the state and meet with different regions of EMS providers, and I'll promote it there. We have a monthly EMS leadership call with all the service chiefs, and we'll talk about it there. And then I'm also an EMS provider in the community, so just personal connections and really promoting the program amongst people that I know are not participating yet. Next slide. So verification, EMS needs to reapply every 5 years. I didn't include that in the slide, but they need to reapply every 5 years and indicate the trainings and community outreach events that they've done. Some of the limitations, I think this is pretty common that a lot of people have mentioned, is just like limited staffing and time. So we haven't been able to do site visits. But one thing that my office is thinking about is how do we incorporate our existing processes and perhaps utilize like our ambulance inspectors when they're out doing ambulance inspections, maybe utilizing them to do some of the site visits around this program. Next slide, thanks. So recognition currently includes a certificate, a plaque, ambulance decals, which is actually going away. We recognize folks on the Vermont EMS for Children website and also on social media during our EMS for Children week. I think this is my last slide, but I'll talk quickly about our hospital emergency department pediatric recognition program that we've been working on. It's mostly, and it's, I guess it's kind of in its pilot phase now. I saw Mark's question in the chat. Yeah, we require a minimum of 4 hours of, I think it's 4 hours of pediatric skills and education training. And also, what are they doing and what are the benefits, like how they're doing it. And for the community education or the community events piece, we also ask folks like, what are the benefits to the community? Who's the audience? And stuff like that. So some of the work that we've been doing around developing a hospital pediatric recognition program, we're modeling it pretty closely off of the work that our other New England counterparts have been doing. And their programs, I believe, are HRSA recognized, but ours is not yet. So we are also calling it the Always Ready for Children program, which is what the program is called for a lot of the other New England states. And we have developed 4 tiers, and it's based on the NPRP score and needing at least one pediatric emergency care coordinator assigned. And so far we've had 14. So we have 14 hospital emergency departments in Vermont that see pediatric patients. And so far we've had 14 hospitals that have been engaged with our project. And this project has been really led by Dr. David Nelson. He's part of our EMS for Children team, but he's funded through the University of Vermont. And he's an emergency medicine physician that, or emergency medicine pediatrician. And so what we do for our program is we have reached out to all the hospitals in the state, and we've emailed them and we call them and we've sent them information in the mail, and we say, hey, let us come to your hospital and do a site visit, and let's walk through the NPRP assessment together and see like where you have any gaps and how we can help address some of those gaps in terms of like policies, or if they need guidance around what the role of a PEC is, and things like that. So yeah, we just started it this year, and we've already had every hospital engaged. So we've done site visits at all 14 hospitals, and all 14 hospitals have done the NPRP survey and have designated a PEC. And this is kind of just the beginning of the project. It's kind of in the infancy stages, I guess, because it's not officially recognized yet by HRSA. So the next phase is like, in the next couple of years, we're going to be, we already have contacts with these hospitals, so we're just going to keep working with them and seeing how we can help support them with their pediatric readiness. And then, yeah, I think the plan is to do this at least every 3 years. Yeah, I think that's it for our Always Ready for Children program too. That was a lot really fast. Sorry, thanks.
No, thank
Does
you,
anyone
Chelsea.
have any questions? And my email's right there too. So if you think of something afterwards, feel free to shoot me an email.
Thank you very much.
Hi, good afternoon. This is Margot Knufflekamp, and I am the program manager for Indiana EMS for Children, here today to provide the update for the collaborative. Indiana EMSC is funneled through Indiana University with an agreement through the Department of Homeland Security that houses state EMS in Indiana. The Indiana Pediatric Emergency Department Facility Recognition Program, it launched back in 2018 post consensus conference at the Indiana Department of Health. Indiana did develop a 2-tier program for the state. You can apply to become pediatric ready or pediatric advanced. We really looked heavily at Illinois' program because at the time we did have hospitals in the southwestern part of the state that were already verified by Illinois' program. And currently we are still in our pilot phase. We launched right before COVID. We actually had our first in-person site verification for 2 pediatric centers in urban Indianapolis 4 days before COVID had entered Indiana back in February of 2019. We currently have 3 sites verified. For quite a period of time, we only had the 2 that I mentioned back from February of 2019. And then in June of this year, we had a suburban hospital to Indianapolis become recognized as pediatric ready in June. Since then, we have done 4 more in-person site visits. One of those, we're waiting for them to provide one more document to meet criteria, and they are a level 3 trauma center that sits on the far central eastern edge of the state. The other 3 hospitals are located in southwestern Indiana and have been a part of Illinois' program. We traveled down there just last month and did their in-person site verification. We're working on documents and plan to notify those 3 before the end of the year. And then also during this time, in the end of October, the 2 that were verified originally in 2019 we went back and were able to do one of the in-persons, and they did receive notification that they were renewed for Pediatric Advanced. And then the other one that's been waiting, they just recently did a complete renovation of their emergency department. So we are going to go in person in March, April. We're actually working with them currently of getting dates for that. How our program looks like for our emergency department is when we were developing the criteria and what our program would look like for our state, we did have Dr. Greg Ferris chair the committee, and we developed a review team. And what that team does is reviews the documents that are submitted, the applications essentially, and they attend the in-person site visit. Our program is built on the 7 domains and the guidelines of care of children in the emergency department. In order to receive an application, because we still are under that pilot phase, emergency department will reach out to me. We do send all the documents via email as a paper application. And once they have the paper application, create all the binders that have all of the documents, we ask that they complete an online application, and that has been really successful in that we are able to send that out to our review team. We do have 3 individuals that will review the application, and then we notify that emergency department if there's anything that's missing, or if it's a good time to go ahead and schedule the in-person site verification. Once we get to the in-person site verification step, it is a 3-hour in-person site visit. We ask that they do a SWOT, so they share with us their strengths, weaknesses, opportunities, and threats when it comes to their pediatric care. And then we do walk through their emergency department and make sure that we go through all of our checklists and make sure that they do truly have what they say that they have. And then post our walkthrough, we do have a closing session, and then we take about 30 days to make sure that they have everything in place. If not, we provide that feedback. And if they do have everything in place, then we will send them a certificate and where their strengths are. And then if we found any opportunities that we thought maybe would be beneficial to their emergency department. Currently, with this year, we had just last year, it came out of the 2021 Public Health Commission. And so during that time, it was determined that our trauma system really needed to be enhanced. We do not have a statewide trauma system plan for Indiana. And so back in August on the 2nd, we Dr. Hout and I, Indiana's program director, and myself presented to the Trauma Commission. And right before we decided to ask to get on the agenda, our advisory board had met, and we had determined at that time that we really want to ask our emergency departments to identify that PEC in the ED. And we know that if we can create this network and have these tools and resources, that ideally we would get more buy-in and more individuals, or excuse me, more entities, emergency departments to apply to become pediatric ready or pediatric advanced. And so we were ready to go. And we get there, and the meeting was 2 hours, and we were second to the end, and our presentation got cut down to, they wanted us to do it in less than 7 minutes. So we tried really hard, really fast, but we weren't able to have that conversation that we wanted to have with the commissioners. But out of that, we were invited to attend working groups. There's several subcommittees that they are that the Trauma Commission's working through. And so I now attend our disaster meetings, system development, and performance improvement. And of those committees, we really want to make sure that they're including pediatrics. And so that's an opportunity for us to work with these groups and just make sure that pediatrics is at the forefront. You know, our health commissioner has said, I want to throw a dart on the state of Indiana, and I want to know where patients are going and have that in place. And so that's really what we're striving to do. December 5th was the first ever Indiana Trauma Symposium that was coordinated, and Dr. Hout did a phenomenal job presenting a pediatric case review and then the importance of the emergency department PEC, or Pediatric Emergency Care Coordinator. And we've had several individuals reach out to us. They want us to work with them on their NPRP gap results. They want us to do presentations and like really look at some of the pediatric cases that they've had in their emergency department. We have a system that we've not been able to get into in the northeastern part of the state. And this system has their tertiary care center. They are a trauma center for level 2 for pediatrics, and they have several critical access hospitals. And so they reached out to me, and my ask to them was, I sent them our criteria. I talked about a future meeting, and I also asked for them to really make sure that what they're doing within their emergency department is really trickling down to their critical access hospitals, and it being an opportunity to really work with them. And so that when there are transfers to their hospital, that those go well and work on their outcomes. And ideally, I want them to go through the process as a unit. So all of their entities going through our facility recognition process for emergency department. And then now that we've had those hospitals apply and have been verified, we really need to sit down. Our team really needs to sit down and review and enhance the criteria that we have that was based back, several years ago now, and the changes, and just really making sure that we enhance our process. Some of the barriers that we are experiencing is we receive feedback from our critical access hospitals, because there are about 18 hospitals that have requested the application, and I haven't really heard from. And so I reached back out to them, and it's time, it's change in emergency department leadership or change in that PEC, really just buy-in with the C-suite. And that's especially with our critical access hospitals. And Indiana has 35 of those. And we have recently had 2 emergency department closures, and there are more that we are anticipating closing next year. I wanted to share, this is the trauma map. And so the goal is to turn this map red. And with this newly formed trauma commission, EMSC is at the table, and they are, there's $7.1 million that entities can apply for. So several of our trauma centers are increasing their trauma status from level 2s to level 1s. There's also some EMS work going on as well. There's simulation and just really wanting to figure out a way to turn this map red, so that if there is an incident, pediatrics as well as adults, any kind of trauma, has access to a trauma center in the state of Indiana. And here is the map, and the H's will show you where the trauma centers lie in the state of Indiana. So our next steps for our emergency department facility recognition program is to revise the criteria. We want to continue to meet with trauma and non-trauma center hospitals. Lots of work with the Rural Health Association. I'm serving my second term as on the board. And so making sure that we are including everything pediatrics with them. They do have an INSERN network. It's an Indiana Small Rural Hospital Network. And Phil Ellis, who is the director for that program, sits on our advisory board as well. And so he makes sure that he pushes out any kind of educational or any kind of information when it comes to that. Continuing to serve on those subcommittee work groups that I mentioned, and developing a PEC network. We do have a current job posting. We're working with the Department of Health Disaster Preparedness Division. 50% of that person's time will be with me working on facility recognition, and then 50% will be with them working with kind of the hospitals and what their pediatric care capabilities, because we know that we have lost inpatient beds throughout the state, and kind of just identifying pediatric tracking and patient tracking and where individuals will go. And then lastly, a little bit about our pre-hospital facility recognition program. And so we have started a work group. This is also chaired by Dr. Greg Ferris, who helped us develop our ED facility recognition program. It's going to look very similar, kind of the structure of what we do for our emergency department. So again, 2-tier, BLS, ALS, so either pediatric ready or pediatric advanced. The committee has looked at the PPRP checklist and the components of that. Our state EMS division is represented on this as well, this subcommittee. And then also we have several EMS agencies across the state, making sure that we're capturing all of the levels and the non-transport BLS agencies, which is about 70% of what Indiana has. We do have close to 700 EMS agencies that respond to public 911, so making sure that we have representation throughout. If you have questions, please feel free to email me, mknefelkamp. I'm sorry, it just changed. Sorry, it's mknefelk@iu.edu. Thank you so much for your time today.
So again, thank you all for sharing updates today about the progress that you have made over the last 16 months. We do have a few updates to share. Firstly, you have received a request. We have received a request from you all to update the maps reflecting your state's current phase. So to do so, we're requesting that you complete the 2024 environmental scan. This is very similar to the environmental scan we shared with you all back in 2023 before the all grantee meeting. So the managers and directors should have already received an invitation to complete the survey. If you have not, please reach out to us and I can help correct that and make sure you have a link to your survey. Currently, we have received responses from 25 states and territories. So we are about halfway there and we look forward to hearing from the rest of you. We also have a brief evaluation survey. We hope that you'll all take a moment to complete. We appreciate your feedback. And again, if you've not received that link, please reach out and I can make sure you have it. Then we would like to thank all those who have responded to our survey requesting input regarding the goals and topic areas for the Pediatric Readiness Recognition Program exchange. We are looking forward to sharing these results with you and discussing our plan for the exchange next month. So you will be receiving a calendar invite for January 16th following today's session, and we look forward to catching up with you all in the new year and discussing our plans for that. There's still time to respond to that survey if you have not yet, so that we can continue to gather your input regarding that exchange. Right, and then finally, on behalf of the PRRPC team, we wanted to wish you all happy holidays, and we look forward to seeing you in the new year. Now we wrapped up there quickly because of time, but if there are any questions, we're happy to stay around and help address those. We appreciate your time and we hope you have a great holiday season.